Good afternoon, everyone, and I really thank Dr. Ashish for giving me this opportunity. And after such a elaborate lecture by Dr. Shamshul Huda, so I'll it has had everything. Probably he has covered my part also slightly, and I will basically try to speak only on ankle arthrodesis and try to make it easy for a normal person. So ankle arthrodesis basically can be a primary modality of ankle fusion, or it can also be a salvage procedure. So I work in Delhi. I'm a professor of orthopedics at Sir Gangaram Hospital. This is my hospital. Now this is ankle joint. This is the cut. The only thing you have to be very careful is two places. One is the anterior laterally, and then one is the posterior medially, where is the neurovascular bundle. So this is the cut 0, and these are the two places you have to be careful. Now there are different patterns of wires, and there is a special kind of wire which is known as console wire. This is the console wire, this has a dart, this is the olive wire, but it does not cross to other side, and it is not a tension wire. So you can fix up a medial malleolus or small pieces of ankle with this wire. So this is console wire, and these are different placements in the foot if you have to extend your frame to the foot. And now there is a issue that if you have to fix, if you have to do pure tibio-talar fusion, then you have to put it in the, if you have to put a wire in the calcaneum, you have to also put a wire in the talus. So because you are doing tibio-talar. So talar wire is required. If you are just putting wire in the calcaneum, you can do both ankle and subtalar fusion, which I will show you subsequently. So there are 3 approaches to ankle joint. This is a teaching video, so you will understand I have made some animations in my way to explain you. So anterior, lateral and medial approach, because sometimes during salvage you require all 3 places to go in. So a fracture which has been done by internal fixation like this can go like this. So it is severe secondary osteoarthritis, and it requires fusion. Now first we come to the medial approach to the ankle. It's a 10 centimeter long incision which is basically behind posterior aspect of the medial malleolus curving forwards. You have to do osteotomy of the medial malleolus, and then you fix the medial malleolus with that method I will tell you how it is done with a screw traction device. So I made this animation. This is an incision on the medial side, direct over the medial malleolus, and then what you do that you remove remove the part of medial malleolus. It is brought down. Then you shave the upper end of talus, lower end of tibia, and remove this piece and just dock it. And you hold it with a K wire, a thick 3 mm K wire, and then you apply the frame. So in ankle fusion, the frame, you don't have to go up, you can come in the mid leg. So first ring we apply 2 to 3 wires, tension wires. Then this is the second ring, and then you connect them. This is the wire basically down. I can put it in the talus and calcaneum both, or if I put it in the calcaneum, then I will put pressure over the subtalar joint also. That you have to decide whether you have to involve the subtalar joint. So this is the way to hold it. It's a very simple frame. Anybody can do it. If you have to extend it to the foot, the attachment is like this. It is like mechano. Wires are very minimum. So anybody can do it. And it looks slightly complicated, but it is not. So this is screw traction device, which I have told you. These are the cannulated threaded rods, and you pull up the piece of the medial malleolus. This is the medial malleolar piece fixed with this assembly. This is the screw traction device, and you can pull it up. So now we see the cases of the medial approach. This is a 20-year-old male, had a road traffic accident leading to compound injury of the ankle. He developed osteomyelitis. So you can't do internal fixation. It's a salvage procedure. So this was the situation. osteotomy, partial osteotomy of middle malleolar was done. Why do we do the middle malleolar osteotomy? Because you have to reach to the ankle joint, you have to remove it. So first X-Fist was placed and then I converted into Ilizarov. And this is the union, you can see, good union. So this is his thing. Now coming to the lateral approach. Now lateral approach is a very, very useful approach. And I basically do all most of my ankle fusion by lateral approach. So it is the similar like what we do for a nail, the distal nail is almost the same approach. So long incision over the lateral malleolus, oblique osteotomy of fibula is done, and then the whole fragment of fibula is taken up like a book, and then you have a good view of ankle and subtalar joint. So this is the animation which I try to do it. So this is the osteotomy of fibula, and you remove the shave the part of tibia and the talus and dock it, and assembly is same what I have told you. 2 rings up and 1 ring down in the calcaneum and talus, and it is attached, and you can hold the fibular fragment with a screw traction device which I have told you. So you can extend the foot frame to the foot or sometimes you don't require it. So this is the cannulated threaded rod. So this is the screw traction device. You can see the olive here. So this is a 56-year-old diabetic patient, had a POTS fracture due to trivial trauma, developed osteomyelitis. So this is infected. I went laterally, removed the plate, and this is the assembly for, I have not put the foot frame. So this is her assembly. The process is going on. Now coming to the anterior approach, it's anteriorly you give an incision and you make a plane between extensor hallucis longus and extensor digitorum longus. You have to be careful about the anterior tibial artery and the vessels and the nerves. So this is just a plain and simple, you give an incision anteriorly, same process, shave it, dock it, hold it with K-wire. So assembly is same for all of them. So very simple procedure. You have to just, now coming to this is a 55-year-old female, had a fracture of lateral malleolus with subluxation of ankle. So I'll show you, this is a trivial looking fracture. It was dislocated. Somebody tried to treat up with a plaster. They applied plaster. She came to me. She removed plaster after 10 days, started walking. She came to me. So what I did that the first instance that I just put a fibular wire and did a distraction. So I thought it will settle down. But it went into progress into arthritis. This is the osteoarthritis, painful ankle. So I did a fusion by the anterior approach. You can see her movements. Now this is a failed ankle arthrosis. I go slightly fast. The screw fixation sometimes fails and this Ilizarov becomes a salvage procedure. So this is a twice failed screw fixation for fusion, and this was done. And this is a gunshot injury which required fusion, so this is done by the anterior approach. Now this gentleman, diabetic, had this situation, Charcot joint. So what I thought, I first aligned it with a hexapod, and once I had aligned it, and then I stabilized it again with this procedure. So this first alignment, and then I did this thing, it went into fusion, and you can see his good fusion. So this is another, sometimes you require bone transport also. So this is the situation, you can see his gait. So somebody tried to do the fusion with a LRS, could not do it, he had infection, removed the fibula, but there was a big avascular fragment there, so I removed it, and this whole transport was done. This is the transport. And just this is basically subtalar, this is the triple fusion. And this arch wire technique is sometimes very helpful. You put 2 wires, bend it towards the ring, slightly above the ring, then bend it, and when you tension it, the bone will come. It's almost finished. I'll just tell you about two or three papers. And this is a paper which shows that ankle arthrodesis is very superior with Ilizarov. This is another paper where ankle arthrodesis with Ilizarov compared to internal fixation. So ankle fusion with Ilizarov is much better than screw fixation because this provides a multi-axial stability. And intramedullary nail versus charcot in the charcot joint, but the nail is good, very good, like Ilizarov. But the problem is that in charcot joint, mostly diabetic, you have to be very careful because, and secondly, if you have to do a primary arthrodesis, you will also violate the subtalar joint. So unnecessary if you have tibiocalcaneal joint fusion and you have to also fuse the subtalar joint. Thank you.
Any questions from the audience?
Sir, any consideration before choosing the approach? What approach we go for orthodesis in patient, lateral, medial or anteromedial approach?
See, lateral is the best because what happens that you can totally see the tibiotalar and subtalar joint. Okay, but sometimes I suggest that you have to do plain tibiotalar and you are starting to apply Ilizarov. So anterior approach is quite easy. Anterior approach is quite easy. But medial approach sometimes is required when you have some problem in the area of the medial side or there is a medial malleolar fracture or there is an infection that side. So you have to approach from that area. So it is, you can do anywhere you want. It is not hard and set rule that it depends on the patient. Yes. Sometimes, suppose there is a neglected secondary osteoarthritis and, patient has a equinus mostly at the, mid-tarsal joint. So I can put a wire and pull it up and correct that also. Sometimes, patient is just keeping it flail and you feel that equinus will develop. So you just one wire and you have to extend it to stabilize it. So you can correct equinus also if it is associated.
One question from my side, sir. When you dealing with the charcot joint, what are the challenges you face, your personal experience?
See, I think charcot joint is a nightmare. Nightmare for orthopedic surgeon and it is also very difficult to treat with the Ilizarov also. Now problem is complicated when it is infected also. But Ilizarov gives the maximum, results if you do operate charcot joint with it, because it provides you can give a very heavy, compression. You can provide multi-axial stability, and you can make patient walk. You apply frame, patient can walk with a thick slipper. They can walk. So I think for charcot joint, my suggestion is always use Ilizarov.
The time of union, the fusion, how much time will take?
Charcot joint is delayed. It might take around 5 to 6 months. And never remove frame early in charcot joint. You have to be very careful. And I always do CT scan to check it. I don't believe on X-ray much because I have to do a 3D CT scan to check it when I remove the frame, and especially in charcot joint.
Thank you. Thank you, sir. Any speaker left?